We are going to present that is stroke part 2, and today I am Dr. Manoj along with Dr. Abhishek and Dr. Rajan going to present. I'm going to present about the neurological examination, and Abhishek is going to present about the stroke syndrome. At the last, Nirajan is going to present about the imaging in acute stroke. Regarding the neurological examination, neurological examination takes a complete neurological exam takes a lot of time. So by doing the practice, it will in future we will going to do in the short period of time. It is a method for a screen which is rapid enough to be applied to the many patient and sufficient comprehensive not to overlook the important abnormalities. In general, patients with abnormal mental status, especially attention problem or disorientation, are more likely to have medical problem rather than the functional or psychiatric illness. अहिले पनि हाम्रो इआरमा कुनै बिरामी अब यहाँ भन्दा पनि अरू अरू ठाउँमा जहाँ अलिकति इमर्जेन्सी एडभान्स छैन त्यहाँ चाहिँ कुनै बिरामी एटेन्सन प्रब्लम र डिसोरिएन्टेसन भएर आयो भने फर्स्टमै सम्बन्धित डक्टर साहबहरूले चाहिँ साइकेट्रिक इलनेस हो भनेर चाहिँ डायग्नोस गरिदिन्छ। त्यो साइकेट्रिक इलनेस भन्दा पनि त्यो मेडिकल प्रब्लम हुन सक्छ कि जस्तो लाग्छ हामीलाई। And in neurological examination, we use that National Institute of Health Stroke Scale, that is NISS score. It is widely used systematic assessment tool, which is designed to measure the neurological deficit. It's composed of total 11 items, and each of which is a score from 0 to 4. It means 0 score indicates there is normal function, where the higher score indicates some level of impairment, and the 11 scores were level of consciousness, horizontal eye movement, visual field test, facial palsy, motor of arm, motor of leg, limbs ataxia, sensory, language, speech, and the last is extension and intention. NIHS score was found to be excellent predictor of patient outcome, and NIHS score greater than 16 indicates a strong probability of patient death, where less than 6 indicates there is a good recovery. So the total score severity from range from 0 to 42, and it does not accurately reflect gait impairment, cortical sensory function, or digital motor function, or memory or cognition. Allows no neuroculture to perform the exam, and however, correlation between the functional recovery and NIHS score was weaker when the stroke was isolated in the cortex region. And increase in the 1 point decrease the likelihood ratio by 17%. So the National Institute of Health Stroke scale, it's 0 means there is a no stroke syndrome. From 1 to 4 there is a minor stroke. From 5 to 15 that is moderate score, and 60 to 20 it is moderate to severe stroke, and 21 to 40 is equal to severe stroke. For this NIHS score, I bring one video. I think it is useful for us to evaluate about the stroke patient. Only do that.
Yeah, good. 1, 2, 3, 4, 5. Thank you. I'm going to test your coordination, okay? Can you take the left index finger, please? Touch the tip of your nose, and now touch the tip of my finger. And again, tip of your nose and tip of my... Good morning. My name is Dr. Punekar. What is your name?
Yvonne.
Hello, Yvonne. I heard you were not well this morning. What happened?
I noticed when I was brushing my teeth that I couldn't feel this side of my mouth and face. And when I was brushing my teeth, I couldn't really grip the toothbrush very well.
Okay.
And then when I was going down the stairs, I noticed my right leg was giving way.
So it was the right hand that was weak and the right leg that was weak.
Yeah.
Okay. Sorry to hear that. I'm going to do a set of assessments on you, Yvonne, just to test your nervous system. Is that okay?
Yeah.
Thank you. What month are we in?
November.
Good, thank you. And how old are you now, Yvonne?
26.
Excellent, thank you. Okay. And can you close your eyes, please? Open them. Excellent. And with the left hand, can you make a grip and release it, please? Thank you. I'm going to test your eyes now. Look at that finger, please, and follow the finger. Thank you. Okay, I'm going to test your vision slightly. Look into my eye, please, Yvonne. What's the finger doing?
It's moving. It's moving. Moving. It's moving now.
Good. Now look into this eye, please, with your left eye, with your right eye. Thank you.
Moving. 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 Moving.
Good. Thank you. Okay. Now show me your teeth, Yvonne. Okay. Excellent. Thank you. Can you squeeze your eyes tight, please? As tight as you can. Good. And now raise your eyebrows as much as you can. Excellent. Thank you.
Good evening.
Okay. I'm going to test your limbs now, upper limbs. Can you lift the left arm up, please? Yeah, at that level, and keep it there until I count 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Thank you. Could you do the same with the right upper limb, please? The right arm. Lift it up to that level. A bit more. Thank you. And can we count 10? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Thank you. Can you do the same with the legs, please? The left leg first. A bit more, a bit higher. Yeah. I'll count 5 this time. 1, 2, 3, 4, 5. Thank you. The same with the right leg now. Lift it up to that level, please. A bit higher. Yeah, good. 1, 2, 3, 4, 5. Thank you. I'm going to test your coordination, okay? Can you take the left index finger, please? Touch the tip of your nose, and now touch the tip of my finger. And again, tip of your nose and tip of my finger. Thank you. Can you do that with the right index finger now? Touch the tip of your nose, and touch the tip of my finger. Good. And again, tip of your nose, and tip of my finger. Thank you. Okay? We'll do it with the legs now, but this time we'll take the left heel, touch the right knee, and take it down the shin. Let's do it once more. Good. Now the right heel, touch the left knee, and take it down the shin, please. And once again, please, Yvonne. Okay, thank you. I'm going to test your sensation now, and I'm going to use a pin which has a sharp end and also a blunt end, okay? And can you close your eyes and tell me if it is a sharp or the blunt end that's touching you, please? Close your eyes.
Blunt. Sharp. Sharp. Blunt. Blunt. Sharp. Blunt. Blunt. Sharp. 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 Blunt.
Okay, that's fine. I'm going to do that on the legs now.
Sharp.
Can you close your eyes?
Blunt. Blunt. Sharp. Sharp. Blunt. Blunt. Sharp.
Okay, thank you. I'm going to put that in the sharps bin. Good. I'm going to test your language now, Yvonne. Can you describe to me what is happening, please, there in that picture?
We've got a lady doing the dishes, but the sink is overflowing. There's water on the floor. And then there's a little boy balancing on a stool that looks like it's going to topple over. He's trying to get cookies out of a cupboard. And there's a little girl as well asking for a cookie.
Thank you. And can you read that, please, Yvonne?
You know how? Down to earth. I got home from work. Near the table in the dining room. They heard him speak on the radio last night.
Thank you. And would you like to name these objects, please?
Glove, key, cactus, chair, feather, and hammock.
Thank you. Okay, and can you read that from top to bottom, please?
Mama, tip top, 50-50, thanks, huckleberry, baseball player.
Thank you. The last test now. Look straight at me, please, Yvonne. Which hand moved?
Both. Both.
Good, thank you. I'm going to touch you now and tell me which side I'm touching. Yeah? Can you close your eyes, please?
Both sides, and the shoulder bit, it was a bit stronger in my left. Again, both sides, but stronger on this side. That was on both thighs, stronger again on the left. And again, both sides, but stronger on the left. And that was both feet, but stronger on the left.
Okay, thank you. I will look at your scan and discuss your findings and then come back to you. Okay, thank you. The NIHSS assessment needs to be done as soon as the patient has had their CT scan by the telestroke consultant on call with the help of the local team. The NIHSS is a severity grading scale in stroke that is used universally before and after a patient is thrombolized. It helps select patients for thrombolysis as well as monitor the response after. It is important that all clinical staff who are associated with stroke thrombolysis be familiar with the NIHSS assessment, as they will be helping the remote consultant perform this assessment. The NIHSS score in this particular example was 4. Most consultants would not consider thrombolysis for a score that is less than 4, and hence 4 would possibly be a borderline score. I would thrombolyze this particular patient at this score unless the patient is rapidly improving and hence will end up with an NIHSS score of less than 4 within the next few minutes.
जुन हाम्रो अहिले भर्खरको भिडियोमा एउटा चाहिँ एनएचएस स्कोरको ग्रेडिङ गर्नुभएको थियो, त्यसमा चाहिँ एनएचएस ग्रेड चाहिँ 4 आएको थियो र लेस देन 6 भनेको चाहिँ गुड आउटकम भनेछ र मोर देन 16 भयो भने चाहिँ मोर्टालिटी हाई छ भने एउटा चाहिँ यसको सेभरिटी पनि एक्सप्लेन गर्छ। अर्को भनेको हामीले त्यो बिरामीको मान्छेहरुसित त्यो काउन्सिलिङ गर्नलाई पनि यसले चाहिँ हेल्प गर्छ। मोर देन 16 भयो भने चाहिँ हाई मोर्टालिटी हुन्छ, लेस देन 6 छ भने चाहिँ आउटकम पनि राम्रो हुन्छ भनेर भनिरहेको छ यो एनएचएस ग्रेडिङले।
Next presentation, good evening, respected faculty members, my senior, my junior, and my colleague. Today I'm going to present a stroke syndrome. So, as you know, strokes occurs when there is either interruption or reduced blood supply to the brain, and when blood supply to the brain is reduced, then brain cells start to die due to deprivation of oxygen and nutrient. So this is a emergency condition, and immediate treatment is crucial. So this stroke syndrome is either ischemic or hemorrhagic. And this ischemic stroke syndrome is further classified as anterior stroke syndrome and posterior stroke syndrome. And this anterior stroke syndrome occurs due to the occlusion of anterior cerebral artery or middle cerebral artery, whereas posterior stroke syndrome occurs if there is occlusion in posterior cerebral artery, basilar artery, or vertebrovascular artery. In anterior stroke syndrome, middle cerebral artery involvement is most common type, whereas anterior cerebral artery involvement is less common type, and it accounts from around 0.5 to 3% of all strokes. And if there is a blockage occurs distal to the anterior communicating artery, then patient present with hemiplegia, hemisensory loss, and in this ACA type, lower limbs are much more involved than the upper limbs, and face is usually spared. But if blockage occurs proximal to the anterior communicating artery, then facial involvement also seen. In anterior, in ACA type, patient also present with history of urinary incontinence. If there is a lesion in the right sided, then patient present with history of confusion and hemi neglect. You hemi neglect vanale patient is unawareness or unresponsiveness to either object or people or any other stimuli. It is not that patient cannot see the stimuli, but patient have lost their will to respond against the stimuli. And this hemi neglect is due to if there occurs, if there is injury to the posterior parietal cortex region, and this hemi neglect is further this hemi neglect is either right sided hemi neglect or left sided hemi neglect, and left both type of hemi neglect occurs, but left sided hemi neglect is more common than the right sided hemi neglect. नर्मली अब सपोज कुनै पेसेन्ट लेफ्ट साइडेड हेभी नेग्लेक्ट छ भनेपछि त्यस्तो पेसेन्टलाई प्लेटमा खाना खान दियो भने अब राइट साइडतिरको उसले खाना खाइदिन्छ होइन, लेफ्ट साइडतिर खाली नै हुन्छ कि खाना बाँकी नै हुन्छ. मेल पेसेन्ट छ, लेफ्ट साइड हेभी नेग्लेक्ट भएको मेल पेसेन्ट छ भनेपछि उसले राइट साइडतिर सेभिङ गरेर आउँछ, लेफ्ट साइडको उसको त्यतिकै हुन्छ कि. त्यही भएर यो क्लिनिकली पनि अब एउटा छुट्याउन सकिन्छ. अर्को भनेको if there is occlusion in the left sided, then patient present with akinetic mutism and transcortical motor aphasia. यो akinetic mutism भन्नाले नामबाटै थाहा हुन्छ. akinetic भनेको not moves, whereas mutism भनेको not speak. It means यसमा मोटर फङ्सनहरू जस्तै स्पीच, facial expressionहरू loss हुन्छन्, but the patient move their eye in response to the auditory stimuli, and it occurs in either due to the frontal lobe damage or thalamic stroke. In most common type is middle cerebral artery occlusion, and यसमा चाहिँ यो एमसीओ को दुईटा ब्रान्च हुन्छ, एउटा कर्टिकल ब्रान्चेस र अर्को भनेको सेन्ट्रल ब्रान्चेस. इफ देयर इज इन्भल्भमेन्ट अफ द कर्टिकल ब्रान्चेस, देन पेसेन्ट प्रेजेन्ट विथ हेमिपेरेसिस और हेमिसेन्सरी लसेस फेस र आर्ममा लिएर आउँछ. अर्को पेसेन्ट प्रेजेन्ट विथ हिस्ट्री अफ एफेसिया. एफेसिया भन्नाले पेसेन्ट there is loss of ability to speak, write or understand. अनि त्यसमा पनि अब नन डोमिनेन्ट हेमिस्फियरमा इन्भल्भमेन्ट छ भनेपछि डिसआर्थरिया चाहिँ हुन्छ, एफेसिया कम हुन्छ. डिसआर्थरिया भन्नाले अब मसल which are used to produce speech are damaged, like there is a damage of either tongue, larynx or vocal cord. So it makes difficult for the person to pronounce words. अनि अब स्पीच प्रब्लममा दुईटा कुरा, एउटा त कि त डिसआर्थरिया भयो कि एफेसिया भयो, जुन अहिले भर्खर कुरा गरे. अब एफेसियामा प्रब्लम विथ ल्याङ्ग्वेज छ, डिसआर्थरियामा अब प्रब्लम विथ आर्टिकुलेसन छ. अब एफेसिया इफ देयर इज प्रब्लम विथ ल्याङ्ग्वेज, यसमा दुईटा कुरा हामीले हेर्नुपर्ने हो. वेदर देयर पेसेन्ट ह्याभ एबिलिटी टु रिपिट वर्ड इज इन्ट्याक्ट अर नट. सो इफ patient have ability to repeat word is intact, then it may be due to the it may be transcortical sensory aphasia or transcortical motor aphasia. अब यो दुईटै फेरि अब क्लिनिकली नै छुट्याउन सकिन्छ यो ट्रान्सकर्टिकल सेन्सरी एफेसिया हो कि ट्रान्सकर्टिकल मोटर हो भनेर। अब ट्रान्सकर्टिकल सेन्सरीमा मेनली पेसेन्ट चाहिँ प्रेजेन्ट गर्छ फ्लुएन्ट स्पिच, अनि यसमा चाहिँ पेसेन्टले रिपिटेड क्वेसन चाहिँ गर्छन् तर त्यसको एन्सर चाहिँ दिँदैन यो ट्रान्सकर्टिकल सेन्सरी टाइपमा। बट ट्रान्सकर्टिकल मोटर टाइपमा यसमा चाहिँ पेसेन्ट प्रेजेन्ट विथ नन फ्लुएन्ट स्पिच हुन्छ, पेसेन्ट प्रेजेन्ट विथ इम्पेयर्ड त्यसको राइटिङ स्किल इम्पेयर्ड भएको हुनसक्छ, डिफिकल्टी इन स्पिकिङ एन्ड दे हेभ डिफिकल्टी इन मेकिङ क्लियर थट्स। यो पनि दुईटा क्लिनिकली नै छुट्याउन सकिन्छ। अर्को कुरा, if the ability to repeat word is not intact, then it may be motor aphasia, sensory aphasia, conductive aphasia and global aphasia. अब यसमा पनि अब जस्तो कन्डक्टिभ एफेसियामा मेनली भनेको वर्ड फाइन्डिङमा डिफिकल्टिज हुन्छ, दोस्रोको डिफिकल्टी इन जस्तो रिपिटेटिभ फ्रेजेसहरूमा डिफिकल्टी लिएर पेसेन्ट प्रेजेन्ट गर्छ। ग्लोबल एफेसियामा पेसेन्ट कम्युनिकेट विथ द पिपुल बाई युजिङ देयर फेसियल एक्सप्रेसन भनेको ग्लोबल एफेसिया। अनि यो माथिको त हामीले अघिको स्लाइडमा कुरा गरेका थियौँ। अनि यो एकाइनेटिक म्युटिजम र हेमी नेग्लेक्टको मैले अगाडि नै कुरा गरेँ। अब posterior cerebral artery posterior stroke occurs due to the either posterior cerebral artery involvement or basilar artery involvement or vertebrovascular artery को involvement हुन्छ। यिनीहरूमा अब जस्तो posterior cerebral artery involvement छ भने क्लासिकल सिम्पटम चाहिँ एटाक्सिया लिएर, एटाक्सिया भन्नाले एबनर्मल अनकोअर्डिनेटेड मुभमेन्ट लिएर पेसेन्ट प्रेजेन्ट हुन्छ। अर्को भनेको निस्ट्याग्मस, यसमा चाहिँ अनकन्ट्रोल मुभमेन्ट अफ आई, त्यसपछि पेसेन्ट प्रेजेन्ट विथ अल्टर्ड मेन्टल स्ट्याटस और भर्टाइगो लिएर आउन सक्छ। बेसिलर आर्टरी इन्भल्भमेन्ट छ भने त्यसमा पनि पेसेन्ट डिजिनेस, युनिल्याटरल लिम्ब विकनेस, डिसार्थ्रिया, डिप्लोपिया, हेडेक लिएर आउन सक्छ। वेरेज भर्टिब्रोबेसिलर आर्टरीको इन्भल्भमेन्ट छ भने पेसेन्ट प्रेजेन्ट विथ आइदर डिजिनेस, nausea, vomiting, headache, dysphagia and unilateral limb weakness. अब यो पोस्टेरियर स्ट्रोक छ भनेपछि अब यसमा क्लिनिकली हेर्दाखेरि युनिल्याटरल लिम्ब विकनेस लिएर प्रेजेन्ट हुन्छ। हिस्ट्री अफ देयर मे बी हिस्ट्री अफ ब्लरिङ भिजन, हिस्ट्री अफ हेडेक और डिसार्थ्रिया, भिजुअल फिल्ड लस, देयर इज अ लाइट टच एन्ड पिन प्रिक सेन्सेसन डिफेक्ट। अनि यसमा एलेक्सिया विदाउट एग्राफिया प्रेजेन्ट। एलेक्सिया विदाउट एग्राफिया भन्नाले पेसेन्टले लेख्न चाहिँ सक्छ बट अनेबल टु रिड, तर पढ्न चाहिँ सक्दैन। अब मेन कुरा भनेको अब यो एन्टेरियर स्ट्रोक हो कि अब पोस्टेरियर स्ट्रोक हो, हामीले कसरी छुट्याउने भन्दाखेरि अब लिम्ब विकनेस एन्ड क्रेनियल नर्भ विकनेस इज इप्सिल्याटरल इन एन्टेरियर स्ट्रोक, whereas in posterior stroke it is contralateral. So clinically पनि हामीले छुट्याउन सकिन्छ। अर्को कुरा अब जस्तो पोस्टेरियर स्ट्रोकमा पेसेन्ट चाहिँ निस्टाग्मस, भर्टाइगोहरू लिएर प्रेजेन्ट भइरहन्छन्। अब त्यो चाहिँ अब त्यसमा चाहिँ अब यो स्ट्रोकको कारणले हो अथवा भेस्टिबुलर न्युरोनाइटिसको कारणले हो, त्यसलाई छुट्याउनलाई एउटा हिन्ट्स भने छ। हिन्ट्स भनेको HI भनेको हेड इम्पल्स टेस्ट, N भनेको निस्टेग्मस र TS भनेको टेस्ट अफ एसक्यू हो। अब हिट यो यसबाट हामीले छुट्याउने हो कि पेसेन्ट आइदर दिस निस्टेग्मस और भर्टाइगो इज ड्यू टु द स्ट्रोक और दिस इज ड्यू टु द भेस्टिबुलर डिसफङ्सन। सो अब हेड इम्पल्स टेस्ट कसरी गर्ने भन्दाखेरि यसमा patients sits face to face in front of the examiner and एक्जामिनरले के गर्नु पर्यो भन्दाखेरि examiner hold the patient head from front, and patient is advised to look at examiner nose, and the examiner rapidly turn the patient's head either to right or left. Uh, uh, and if the right ear is intact, if the right ear is intact, that is there is a intact vestibular function, and when head is turned to right, then the vestibular reflex move the eye to maintain the visual function. But if there is a impaired vestibular function, and when the head is turned to right, the eye moves with breaking visual fixation. अर्को टेस्ट भनेको अब निस्ट्याग्मस छ. निस्ट्याग्मस अब हामीले एज वी नो दिस इज आइदर युनिडाइरेक्सनल अर बाइडाइरेक्सनल. अब यो त हामीले अब्जर्भेसनबाट नै थाहा पाउने हो हैन. राइट ल्याटरल गेज छ अर लेफ्ट गेजमा छ भनेपछि कुनै इफ देयर इज नो निस्ट्याग्मस देन इट मिन्स नर्मल. इफ देयर इज vertical or bidirectional nystagmus, then there may be the involvement of the central pathology. अर्को तेस्रो भनेको हिन्ट्सकै टेस्ट अफ एस्क्यू हो. यसमा मेन कुरा कसरी गर्ने भन्दाखेरि पेशेन्ट इज आस्क्ड टु लुक एट द एक्जामिनर नोज and cover patient's one eyes, and then rapidly uncover the eyes. If there is central cause of vertigo, if covered eye is suddenly uncovered, vertical alignment of eye may be different, and vertical corrective movement seen. Next part चाहिँ imaging in stroke निराजनको छ.
Good evening, respected faculties, my dear friends, and my juniors. Today I am Dr. Nirajan Shrestha. Today I am going to present on imaging in stroke. There are in diagnosis of imaging, in diagnosis of stroke, there is various modalities of imaging, and they are unenhanced CT scan, MRI, magnetic resonance imaging, angiography, and perfusion imaging. On CT scan of head, 60% of infarcts are seen within 3 to 6 hours of impaction, and virtually all are seen in 24 hours. MRI is superior to non-contrast enhanced CT in the detection of acute infarction, but there is some limitations of MRI, which in which it takes time and to perform the MRI, and it takes more cost to the patient. So commonly non-contrast CT are the first line imaging modalities to detect in the diagnosis of stroke. In ischemic stroke, there are various phases: hyperacute, acute, subacute, and chronic. Hyperacute phase means which can in which we can in which it is seen within 24 hours, and in acute stroke that the time limitation is 1 to 3 days, and in subacute stroke it is divided into two parts: early and late. In early stroke, that is detected more than 3 days up to 1 week, and in late stroke 1 week to 1 month, and in chronic stroke that is more than 14 days, and it may be up to more than 1 month also. Up to in the CT scan features of strokes, there are various feature of stroke which we can see in the CT films. They are hypoattenuating brain tissue, obscuration of lentiform nucleus, dense MCA sign, insular ribbon sign, and loss of sulcal effacement. Hypoattenuating of brain tissue. Uh, in hypoattenuation of brain tissue, there is loss of gray and white matters. So in this arrow, we can see the hypoattenuations of brain tissue in M2 territory compared to contralateral left side. Hypodense MCA sign. This hyperdense MCA sign is a early sign of early sign of ischemic stroke. It is an acute thrombus in intracranial vessels. Typically has high attenuation. That means hypodense. Although this sign is highly specific but less sensitive. uh, in this picture, we can see that there is hyperdense lesions of in MCA in right side of middle cerebral artery compared to left-sided MCA and basilar artery. Uh, in this picture, there is left-sided hypodense lesion of MCA as seen compared to right side. There is hypodense of MCA, right MCA and basilar artery. Insular ribbon sign. Insular ribbon sign is a hypoattenuations of insular cortex. We can see in left side, which is shown by this white arrows, and this is clearly demarcated by this white arrows. This ribbon-like structure is a insular ribbon sign, and this is a band of hypodensity. Hypodensity. It can be recognized only in case of acute ischemic stroke, and this is a specific sign of MCA occlusion. Another sign is obscuration of lentiform nucleus. It is also a very important early sign of acute ischemic stroke. We can see normal outline of lentiform nucleus in this right side, like triangles, and this is a normal. This is the outline of lentiform nucleus with a dense shaped basal ganglia. Dense shaped basal ganglia, and right side, if you see in the left side, in left side, if you see in left side, lentiform nucleus is completely obscured. That means we cannot see the lentiform nucleus in left side, and this means entire lentiform nucleus is hypodense. The margin of internal capsule and external capsule is also obscured, and the lining has lost. This causes obscuration of lentiform nucleus because of occlusion of middle cerebral artery. Loss of sulcal effacement. In this picture, we can see normal sulci in the right side, but in the left side we cannot see the sulcus, and we can see normal gray white matter differentiation in the normal brain tissue in the right side. In this side there is normal gray and white brain white matter differentiation, but in left side where the ischemia has occurred, infection has occurred, this sulcus has lost, and loss of gray white matter differentiation. The same we can in this ring we can see the sulcal effacement. We cannot see the sulcus, and differentiation, we cannot differentiate of gray and white matter. Now we have discussed of acute stroke signs, and now I'm going to discuss on subacute cerebral infarct. There are various signs we can see in the CT scan film. They are edema, mass effect, hemorrhagic transformation, and fogging effect. Uh, in this picture, there are three pictures A, B, and C. So, seeing this picture, which is subacute stroke and which one is chronic stroke? Can we say this? Yes, we can say that. We can explain and we can say that after this presentation, which one is chronic and which one is subacute stroke. Uh, in this slide, there is various stage of stroke revolution and various changes in the stroke, various changes in the brain tissue after stroke, and according to the time. In the day zero of uh, stroke, we can only see the it is very difficult to detect, and which is there will be loss of white and gray matter differentiation, so that hypoattenuation of brain tissue can only be detected. uh, so from this CT picture, we can see general pattern of revolution and serial CT changes. After a few hours of onset of ischemia, loss of gray white matter differentiations will occur, and that is hypoattenuation. And gradually, in few days, there will be swelling and hypoattenuation, and in fact, becomes more defined. So, in this third day, the infection has becomes more defined, and in the middle of first week, there will be maximum swelling, and there will be we can see mass effect. So in this uh, fourth picture, we can see the mass effect due to the edema and swelling. The falx cerebri has uh, pushed to the left side, and there is infection in the right side. Uh, and after that swelling, then gradually after that, after first week, and the swelling will gradually decrease, and it will start to subside, and hypoattenuation also decreases, and swelling also decreases. In some patient, returning to normal, that is called fogging phenomena. So this fogging, it is a phenomena uh, in a CT scan of head, that is vanishing sign of an infarct on the serial CT imaging in a patient with recent strokes. It is a reversal of hypodensity on CT after an acute ischemia has resolved. Uh, in this picture, we can see the subtle loss of gray white differentiations. And in this slide, we can see the swelling and hypoattenuations of swelling and hypoattenuation effect. There is swelling and there is mass effect also. And swelling and hypoattenuation has reduced. Previously, there was swelling, and now it has reduced, and hypoattenuation also has reduced. So, as I've already described on fogging, uh, now on MRI brain. MRI uh, uh, nowadays, MRI has becomes most popular in the diagnosis of acute ischemic stroke, but there is some advantage and there is some disadvantage also. एमआरआई चाहिँ किन नगर्ने त भन्दा एक्युट स्ट्रोकमा यदि सिटी स्क्यान एभाइलेबल छ भने चाहिँ सिटी स्क्यान चाहिँ अब गर्न सजिलो पनि छ, इजिली एभाइलेबल हुन्छ र सस्तो पनि हुन्छ। र एमआरआई चाहिँ अब गर्नलाई टाइम चाहिन्छ, टाइम लिनुपर्ने हुन्छ र पैसा पनि धेरै लाग्छ। त्यो हुनाले चाहिँ यदि अब सिटी स्क्यान नै चाहिँ हाम्रो चाहिँ फर्स्ट लाइन चाहिँ इमेजिङ मोडालिटिज हुन्छ। सो there are some advantage of MRI. It helps in most accurate evaluation and of stroke size and location. कहाँनिर चाहिँ स्ट्रोक छ भनेर चाहिँ हामीले सिटीमा देखिएन भने चाहिँ हामीले एमआरआई गर्नुपर्ने हुन्छ। र it helps in detailed brain tissue evaluation. There are some potential disadvantages, that is cost is high, time consuming, and it is contraindicated for some patient like who is using pacemaker, metallic implant or dental implant. अब एमआरआई चाहिँ कुन चाहिँ एमआरआई गर्ने भन्दा डिफ्युजन वेटेड इमेजिङ is the gold standard in the diagnosis of acute ischemic stroke. Other modalities are MRA and perfusion weighted imaging. So in MRA, MRA will helps to detect the accurate occlusion site, and it will helps to detect the stenosis site. So in this arrows we can see the occluded area of this MCA, and we can detect the accurate infraction site. Any questions? Thank you.